This is Spencer King for JACC Cardiovascular Interventions. I'm here at the European Society of Cardiology meeting. We've got a fascinating interview to do with Professor Patrick Serruys regarding a blockbuster trial. Patrick, we're interested in hearing about the Syntex trial. We've all been anxiously awaiting this trial, which finally compares drug-eluting stents to surgery, all the advances through the years. Can you tell us what the trial is setting out to test and what the primary endpoint was?
Yes, this is an all-comers trial, so we tried to recruit a maximum of patients. There were a randomized arm and two nested registries for the all-comers. The primary endpoint was based on MACE, all cause of death, stroke, MI, and any revascularization. That was the primary endpoint, and we use as statistical technique a non-inferiority approach with a margin of 6.6%. That means we percutaneous doctors, be 6.6% behind the MACE rate of the surgeon.
Okay, before you tell us the results of this trial, the patients entered were clearly higher risk than any previous trial, with left main representing about 700, as I understand it, and the rest triple vessel disease. Did you get the kind of patients that you were shooting for?
Yes, we indeed have 700 left main, 1,100 three-vessel disease, and in the registry, 1,275 patients, large majority bypass surgery patient, and then a minority of PCI 198 that the surgeon didn't want to do or to treat.
So your endpoint was a combination of all the adverse effects plus revascularization, if we call that adverse or not, but it was all MACE, death, MI, stroke, and re-intervention of any sort. Did you make your non-inferiority margin?
The difference in MACE for the two groups, the main stem and the three-vessel disease, was finally 5.5%. The PCI being behind the surgical cord. But you have to have the one side 95% confidence interval, so the value become 8.1%, and then you cross the margin of non-inferiority, which was 6.6%. So technically, from a statistical point of view, you have to declare that the PCI is inferior to bypass surgery. In other words, the criteria of non-inferiority was not met.
Yes. So it's important, I think, for our listeners to understand the difference in the way this trial is set up and the old trials that we had, like the East and Barry and Gabby and the trials that were measuring only events such as death, infarction, and stroke. Here you've added in the re-intervention as a part of the endpoint. And if we go back to just the endpoints that many patients are concerned about, death, infarction, and stroke, what was the difference in the two strategies given those endpoints?
That's very good. Indeed, death, stroke, and MI are quite irreversible event, and that counts for the patient. And then the numbers were 7.7 and 7.6%. In other words, there were no difference between surgery and PCI for what we consider the safety outcome.
So from a safety perspective, it looks pretty even at 1 year, and the questions, I guess, will arise that 1 year seems like a short follow-up. I know that's the primary endpoint. How long do you plan to follow these patients?
We are going to follow these patients for 5 years, and of course, some of us are legitimately concerned by a potential slow erosion due to stent thrombose, but we have seen that at 12 months in symptomatic patients by angiography, we have exactly the same number of graft occlusion and stent thrombose 3.2. So maybe in the long term it will be less dramatic than expected.
So finally, let me ask you, in the United States, the guidelines say left main disease is verboten. You're not supposed to do it. How do you think this trial might drive attitudes toward doing stenting for left main disease?
I think that if you look at the main stem, you must realize that the non-inferiority test is hierarchical. It covers not only the total population, but if the total population fail, you are not entitled to make statistical judgment on the main stem and on the three-vessel disease. So basically, we end up with a lot of observational data. It is interesting that in the main stem group, 705 patients, there is no difference. 15 and 17% of males for surgery and for PCI. And there is even two groups, the isolated main stem and the main stem with one vessel disease, where the outcome of PCI is superior to, at least numerically, to the outcome of surgery. So I think that we will have to dissect this trial in great detail and make use of the syntax score, which again allow us to modulate this yes and no response, which is coming from the non-inferiority criteria.
So my take-home message, and I realize it's all hypothesis generating, but it seems as though the greatest problem that you've run into is making this work for diffuse triple vessel disease more than perhaps left main disease. And maybe we'll learn more as we get longer follow-up.
Yeah, Spencer, I think that what you say is an interesting paradox. It is not fully exposed in a scientific way, but that's the impression, is that the main stem was in some way more easy than the complex three-vessel disease, and it is for us interventional cardiologists sometimes more difficult to do three-vessel disease than main stem. That's something which has to be demonstrated by numbers and statistics, but it's a kind of take-home message here.
Patrick, you're to be congratulated for this outstanding study. You continue to make major contributions to our understanding of what we can do for patients suffering from this extensive disease. Thank you for visiting with us very much.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.